Hello, everyone. Welcome. I am so excited that you have joined us for our 40th annual NAMI Maryland conference. My name is Kate Farrenholt. I'm the executive director of NAMI Maryland, and we are just so excited to have the most amazing lineup for this two-day conference. Here we go. First, a little housekeeping. We are recording our presentations. Participants will not be included in that recording, so don't worry. We're also pleased to offer closed captioning for this year's conference. Captioning is only available for attendees who are using a desktop or a laptop. To enable captioning, please click on the CC icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, post them to our chat and our technical assistant will address them accordingly. I am excited to introduce you to Denise Evans, Vice President of our wonderful Grassroots Board of Directors. Welcome, Denise. Have a few words.
Thank you, Kate. On behalf of Joe Ashworth, who is the president of the NAMI Maryland Board of Directors, but cannot be with us here this morning, I'm so delighted to add my welcome to each of you to NAMI's 40th annual conference. Wow, Kate, what an accomplishment. And as Kate said, I'm Denise Evans, first vice president of the NAMI board. My involvement began with NAMI about 18 years ago. I fell into a NAMI 12-week family-to-family class, and it changed my life. It enabled me to effectively advocate for and support my loved ones. So briefly, I'd like to thank each of you for taking time out of your busy schedules to attend this two-day conference and our annual meeting on Saturday morning. Thank you to our distinguished speakers, volunteers, and a huge thank you to Kate and the NAMI MD staff for their dedication and excellence in putting on this conference. Kate, off to you.
Thank you, Denise. And your story is one of many that makes NAMI so special. What once started as a one-day, one-track conference in 1982 has grown into a 5-session, 2-day conference, and it's a celebration of the greatest minds in mental health. We're sharing practical information and resources about emerging research, social benefits and support, marginalized communities, health disparities, and again, practical, useful information on how you can help yourself, your loved ones, the people you work with, and advocate. It's an exciting time for NAMI Maryland, NAMI National, and mental health. The COVID-19 pandemic has brought mental health to the forefront of the conversation. And NAMI is leading the way as one of the preeminent organizations, providing necessary support, education, outreach, and advocacy to everyone whose mental health has been affected. I wanted to briefly just share a few, some information, okay? When I first came to NAMI 26 years ago, I was stunned to realize that my family was not unusual. I learned that my sister who had schizophrenia and my family who was dealing with my sister who had schizophrenia were not alone, though nobody told us. 1 in 100 people will experience schizophrenia in any 1 year. 1 in 5 families are affected by mental illness, and everyone is affected. According to the World Health Organization, mental health and mental illness affects everyone in many ways. 5 in 10 of the leading causes of lost productivity and even disability are mental health problems. Mental health disorders are usually one of the top 3 causes of disability, together with cardiovascular disease and musculoskeletal disorders. In the US, estimates for spending on depression alone are $30 to $40 billion each year, with an estimated 200 million days lost from work each year. And this does not include the cost of family members and caregivers calling in sick or being distracted at work. We are all affected. My family came to NAMI because we needed help. We needed information. We needed to feel that we were not alone, and we needed to have the most recent research and access to the best doctors, and we got those through the advocacy of NAMI members. NAMI is the nation's largest grassroots stakeholder-oriented organization dedicated to building better lives for the millions affected by mental illness. We are a national organization with state organizations and local affiliates. Very briefly, I want to note what our values are. Our values are hope. We believe in the possibility of recovery, wellness, and the potential in all of us. Inclusion. We embrace diverse backgrounds, cultures, and perspectives. Everyone is affected somehow. Empowerment. We promote confidence, self-efficacy, and service to our mission. Compassion. We practice respect, kindness, and empathy. And fairness. We fight for equity and justice. How does NAMI make things happen? NAMI is all about the empowerment of individuals and family members living with mental illness. We, are our core stakeholders and our leaders. We are the experts. We have direct experience. The power of personal experience, now called personal narrative, can change audiences and change minds. Having a mental illness happen to one's family or directly to you is traumatic, and NAMI transforms trauma into positive action and change. Everyone is affected somehow. It directly hits them, they work in the community with, or it's affecting our bottom line, business and taxes and so on. Small groups can engage and activate large groups of passionate volunteers. We've proved that through NAMI. And we leverage the networks and affiliations of our many stakeholders and our partnerships with caring organizations, like the ones that many of you are associated with. Thank you again for joining us. I'm excited, beyond excited, to welcome several special guests for this year's opening plenary to share exciting information about the new National Crisis Line, 988, and other NAMI priorities. Please join me in welcoming Hannah Weslowski, who is the Chief Advocacy Officer from NAMI National, and Dr. John Palmieri, the Acting Director of the 988 and Behavioral Health Crisis Coordinating Office from the United States Substance Abuse and Mental Health Services Administration, SAMHSA. Thank you for both joining us today. Hannah, over to you.
Thank you, Kate, for that warm welcome. And NAMI Maryland is just such a wonderful organization. I have worked closely with Kate since I think my first week on the job at NAMI National almost 6 years ago, and just so grateful to be with all of you and talk about these important topics. I'm just going to give a brief intro and turn it over to Dr. Palmieri, who I'm so grateful to him for being here today. But from the national office perspective, we've really prioritized 988. It is a truly transformative opportunity that we have to fundamentally change part of the mental health system. And that's a rarity. For many years, as I don't need to tell all of you, mental health has been underfunded. We haven't had the resources, we haven't had the focus. And for the last few years, that has changed in a significant way. And if we harness the opportunity of 988 as the entry point for a crisis continuum of care, we can vastly change thousands, millions of lives across the country, not only the individuals in crisis, but their families as well. We know too well what happens right now when people are experiencing a mental health crisis. And For the most part, it's not good. The outcomes are often tragic, traumatic, and 988 gives us a real chance to do things differently. We have strong consensus across the mental health, substance use, and suicide prevention community, both from nonprofit organizations, providers, as well as our government partners like SAMHSA. And we also have unprecedented investments. And so this is a real opportunity, which is why NAMI has prioritized our initiative to reimagine crisis. I am deeply grateful for the momentum, the advocacy provided by all of you to make this possible. I am honored to turn it over to Dr. Palmieri now to talk about where we are with 988. But one thing I want to make sure we emphasize today is 988 is one part of reimagining crisis. And there's a lot of work happening in Maryland at the national level at SAMHSA and in states across the country to make sure that we continue the momentum of 988 and truly leverage this amazing once-in-a-lifetime opportunity. So with that, thank you so much for having me be here. I'll say more later, but happy to turn it over to Dr. Palmieri. Thank you.
Thank you so much, Hannah, and thank you, NAMI, for being such wonderful partners as we work together to meet the needs for individuals in crisis across the country and really maximize, take advantage of this opportunity that Hannah was talking about to transform the system into something that is trauma-informed, person-centered, and meets all of those individual family needs. So I'm going to spend just maybe 15 or 20 minutes kind of walking through some slides here to speak a little bit, kind of providing an overview at the federal level from our perspective in terms of what we've been doing with respect to 988 and kind of where we're going moving forward. So I probably don't need to spend a lot of time here, but and Hannah referenced this as well, but we know where we are currently. I mean, there is a crisis in this country with respect to mental health and substance use care and access to care. And we know that there are lots of people who are not able to access care for lots of different reasons. But the result of that is that crisis situations often develop because of lack of opportunities to prevent those earlier on in the course of one's illness or distress. Suicides remain commonplace, overdoses remain commonplace, and unfortunately, law enforcement response to crisis situations remains commonplace. And so here, just kind of describing sort of this context that we're sitting in, where there are tremendous opportunities for us to work toward transformation to better meet the needs of individuals. So some of this information comes from SAMHSA survey data, but I'm sure many of you have been tracking in the news. There's been other surveys that have been published recently through the Harris poll, through CNN and Kaiser Family, and they're all telling the same story, which is that there is a crisis in this country and people are having a hard time accessing care. And so this is really what we're trying to improve upon. For those of you who don't know, I'm not going to go through the whole timeline of the Suicide Prevention Lifeline, but just for those of you who maybe are less familiar with how 988 fits in here. So the National Suicide Prevention Lifeline has existed since 2005 through the 800-273-TALK number. That number is not gone away, so that number still exists as a portal to the Suicide and Crisis Lifeline. So the National Suicide Prevention Lifeline has been kind of rebranded as the Suicide and Crisis Lifeline. And 988 has become that easier to remember portal, easier to remember number as a way to access those life-saving services through the Suicide and Crisis Lifeline, because we wanted strongly for people to have reduced barriers, reduce stigma, increase access to life-saving services. And so you can see here over the course of the past 17 years or so, there's been a lot of activity in both building the capacity of the Lifeline, increasing channels of communication, so that it's not just calls, it's also chat and texts. And then more recently, kind of the federal legislative activity that basically established the 988 code and then linked it to the Lifeline as that kind of new, easy to remember portal as a way to access those services. And this slide, I mean, things are moving so quickly that it doesn't take long for slides to get out of date. And so this slide is actually out of date. But just as a way to kind of reference sort of how the system sort of works and with the structure. So basically in FY21, there are about 3.6 million contacts. We're expecting significant increases in volume with the transition to 988. And we're already seeing that post the transition on July 16th. But technically, so if people call in, use the 988 number or the old 800 number, they're given a couple of options. They can connect to the Veterans Crisis Line. They can connect to a Spanish subnetwork. Now they can actually connect to LGBTQ plus youth services, and I'll talk a little bit more about that. If they remain on the line and don't present an option, they're connected to their nearest local crisis center based upon the area code that they're calling from. And if that center is kind of at maximum capacity and they aren't able to respond quickly, then the call gets routed to a national backup center. And then texts and chats have historically been answered by a subset of centers that provide text and chat service, although that also is changing. So states and localities actually are increasingly responding to texts and chats. So that's moving toward a more local response, which we think is very important overall in integrating service wraparound and follow up with those individuals in crisis at the local level. We know that I said the service has been in place since 2005, and we are building on an existing infrastructure. So 988 is building on the lifeline that has existed for all these years. And there have been lots of evaluation studies looking at outcomes of the lifeline and have shown that for people following crisis contacts with lifeline counselors, they feel less depressed, less suicidal, less overwhelmed, and more hopeful. So we're building on something that we know has proven success moving forward. The next two slides speak to a number of activities that we have been involved in and at the federal level with respect to 988 transition over the past year or so. I'm not going to go through every single one here because it's a lot of detail, but I will just highlight a couple of things that I think are important. One has been really the kind of the development of a structure within SAMHSA, within the federal government, that's exclusively focused on 988 and crisis coordination more broadly. There have been lots of programs for many years at SAMHSA that have supported crisis services and the lifeline, but there had not up until last year been kind of an office structure that is exclusively focused on these activities, which we felt was important as SAMHSA is a leader in the field and wanted to be able to bring together partners, guidance, funding, technical assistance to support crisis development. And so with that has also come, as Hannah said earlier, unprecedented funding to support the crisis system. I'll talk a little bit more about that in the next couple of slides, but the lifeline historically has been significantly underfunded and under-resourced, and there have been some significant changes in the past year and even more changes to come as projected in future years. With respect to operational readiness, we have leveraged a lot of that funding to focus on building workforce and building capacity in the lifeline system to respond to those calls, chats, and texts quickly. We know that because of underfunding, there have been historic challenges in those responses and in those response rates and the amount of time people have to wait to be connected to crisis counselors, particularly through chat and text. And so those investments and the capacity building has had a meaningful impact on the lifeline response, and we'll talk a little bit more about that. And then we also are actively working across the board with our partners on an important piece of work that has to do with 911, 988 coordination. We want to make sure, there are lots of calls, we talked about this at the beginning, lots of calls related to mental health or substance use crisis that are going to the 911 system that end up activating emergency medical personnel or law enforcement. And we want to be able to have those calls be directed to more person-centered care where it's appropriate to do that. And so the coordination that's required between 911 and 988 is really important to make sure that we are maximizing opportunities to divert crisis response from 911 to 988 so that people can get directed to kind of their treatment and recovery supports that they need to help them get through the crisis. On messaging and public communication, we have done a lot of work here with partners. I would not have been able to do any of these things without partners. With respect to developing a messaging framework around 988 and more significantly, a partner toolkit, which is on our SAMHSA website, which I will show you a slide about that later. But the partner toolkit really is intended for for everybody to use for dissemination purposes. It has key messages, FAQs, printable materials, social shareables, intended to be used by everybody on this call and beyond, partners, their communities, people they're serving, to promote awareness of 988 and the services that exist for anybody 24/7 when they're in crisis. And then we are also in the last section here very much focused on how 988 fits into this broader crisis conversation. Hannah referenced this earlier because that part is critically important. 988 is essential and it's not sufficient. We need other things that be connected to 988. We need a full crisis continuum. We need a full behavioral health continuum. So we need mobile crisis services, crisis stabilization services, but we need prevention services, early intervention services, peer recovery services. We need it all to fit together in a coordinated way. And so we are very much focused on that sustainability piece. How do we build out that system that we want to see? How do we fund it? How do we find the workforce that's going to be required to sustain that system? How do we evaluate the system? How do we make sure it's equitable? Those are all questions that we need to be asking every day as we move forward in transforming the system. Just here, these next several slides are mostly performance data from August. We are finalizing our performance data from September, so we should have that soon, but just wanted to sort of show you with the investments that we've made that there has been significant improvement in the performance of the Lifeline. We certainly have a long way to go still. This is not, I'm not at all suggesting that we're kind of done here. We have a lot more to do. There's always room to improve, but we have made a lot of progress. So if we look at August of 2022 compared to August of 2021, as I said before, there has been a significant increase in volume, 45% increase in overall volume in August of this year compared to August of last year. And that has translated into about 150,000 plus more contacts that have been responded to through the Lifeline in August of this year compared to August of last year, which is significant. These are people in crisis, thousands and thousands of people in crisis who are able to get connected to trained crisis counselors. And so that's significant. We also know that the chat and text response has increased tremendously. I mentioned before that there were historic challenges here. So you can see in the middle section for chats, the response rates were hovering around 30% last year. They're now 97%. And then for text, 63% to 98%. And text is the area since the transition in July where we've seen the most growth in terms of volume. The text growth has been large. And we know that for chat and text in particular, most of the individuals who are using those communication channels are younger. About 75%, I believe, under the age of 25. And many of those individuals are more acutely distressed based upon kind of pre-chat, pre-text surveys that they're either endorsing active suicidal ideation or recent suicidal ideation. So with the chat and text capacity, definitely being able to respond to the needs of a younger population that we know to be more acutely distressed. And so that's important. And then the average speed to answer, I mentioned this earlier. Overall, I mean, the message here is that we have been able to improve that. So people are waiting for less time to be connected, which is also critically important because the longer people wait, we know that it's more likely that they're going to drop the call because they're tired of waiting. And so we don't want to create that situation. And then here's a slide that just kind of speaks to historic funding. I mean, I guess it's here for dramatic purposes. I suppose, I don't know. But you can see here, I mean, just how much growth there's been in the funding and the investment at the federal level to support 988 transition going back to 2007. So FY22, we're here at 432 million. For those of you who are tracking President's budget and projected House appropriations language for FY23. We're looking at around 700 million. And so there's been tremendous movement in a positive direction here. And then here, I'm just going to go through quickly in the interest of time. So these next several slides basically are kind of telling the same story that I just sort of laid out on the previous slide, which is calls are being answered faster. Calls, chats, and texts are being answered faster at a higher percentage with higher volume. And these slides really are intended to illustrate that you can start to see the significant improvement around the March, April of this year timeframe, which is when those investments actually went to centers, went to states and territories to actually work to build that capacity. So there is a correlation between the federal investment and the performance. It's kind of all tell that same story. So I'm just going to scan through these quickly. This is chat answer rates and volume. This is the average speed to answer, which you can see has gone down significantly for chat. Similar story with text. You can start to see movement in the spring, early summer with respect to volume, with respect to answer rates. And then again, average speed to answer gone down significantly for text. For calls, the changes here are not as dramatic, but you can see here that even with a significant increase in volume in June, July, and August, answer rates have continued to sort of go up. The trajectory has been upward, even though it's not been as dramatic for chat and text as it is for chat and text. And then here you can see the average speed to answer for calls as well continues to go down, which is all very positive. And then I just want to flag here, we do also pay attention to local performance. And so we are tracking kind of how states are doing with respect to local response, because we do think that that's important. And states have done a great job. I mean, overall, I mean, I think that if this is from August of 2022, so we sort of kind of organize states, state answer rate, so in-state answer rate for calls coming in through 988 and the degree to which they're able to respond to those. And if I showed you this slide from June, you would see many more states to the right of this slide. And in August, 46 states and territories are in the two columns to the left, which is tremendous progress. I mean, I can't overstate that. It is tremendous progress. States have worked very hard to build up capacity, and so very appreciative of that partnership there. I did mention the SAMHSA webpage. So here at samhsa.gov, there's a whole range of 988 resources, including a partner toolkit. On the partner toolkit, this is again where you can find lots of information for messaging and communications, fact sheets. We're constantly updating this material when things arise or questions arise or controversies arise about what 988 does and doesn't do. We've updated materials based upon recent confusion about whether geolocation capabilities exist within 988, which they do not. But we are constantly sort of updating the material to reflect questions, like legitimate, reasonable questions that the field has about 988. And we want to make sure that we are putting out the most accurate information about 988 that can be shared in everyone's communities. Just for a minute here, highlighting that we did create a jobs page for 988 centers. I did mention workforce as a challenge. I'll mention that again in a couple of minutes. But we know that this is a challenge. We know that across the board in the behavioral health space, it's challenging to recruit and sustain workers, professional licensed folks, peer support workers, paraprofessionals. It's just been challenging. And so we wanted to use whatever strategies we could to kind of both amplify the visibility of job opportunities and also think about ways that we can support recruitment, retention of workforce, whether that's through career pathway development, training, loan repayment, resilience and support for workers, because we know that we want to make sure that workers are attending to their own health and well-being as well. So those are all things that we're actively engaged on. This is just one piece of that, which is the amplification of crisis center work opportunities. So people can go to this website to click on a crisis center. You can see it links to their jobs page if people are interested in paid or volunteer opportunities at the crisis centers. And then we are also underway with some communications formative research, particularly looking at populations that we know to be at higher risk of suicide, because we want to make sure that as we work toward develop a broader national campaign in the year and years to come, we want to make sure that we are designing that campaign based upon research for how those populations prefer to communicate, who are their influencers, what is knowledge, attitudes, and beliefs about help-seeking behavior, and so forth. So we want to make sure that the campaign ultimately is effective in reaching the people that we know to be at highest risk of suicide. When we're thinking about the future, just pivoting here for my last few minutes, we have organized a lot of our thinking around continuing to strengthen 988 operations, and then also thinking about kind of that broader crisis system and how we're building that out. So with respect to 988, we're continuing to push for enhancing performance, getting all channels of communication above 90%, and ideally at the local level. I didn't mention this earlier, but one of the areas where we have struggled a little bit is in our Spanish subnetwork. And so we are working very hard to improve our response for callers who are Spanish speaking. We are also working to implement Spanish chat and text. We think that increasing language access across the board is something that's critically important. And so Spanish chat and text is on our plan for FY23, as is video-based service for individuals who are deaf and hard of hearing. This is a service that exists currently through the Disaster Distress Helpline, and something that we are planning to implement as part of the 988 system. We are continue to drive awareness. We want to make sure that we're supporting under-resourced and marginalized communities. We're doing a lot of work right now in tribal communities, tribal nations, with some technical assistance. We also did recently put out a grant opportunity for tribal nations and tribal organizations to support 988 response. And so those are just two examples. We are also underway with a pilot for LGBTQ plus youth who can access specialized services through the Lifeline. So those are just some examples of ways that we're building upon that. And then we are also continuing to work toward that 988 911 coordination, and how we're effectively routing callers to local centers in the best possible way, while paying attention to the privacy concerns that exist for individuals. And then for the crisis services, we are developing both within the Department of Health and Human Services and more broadly across the federal government, kind of a roadmap or an integrated plan for what lots of agencies and departments are doing to support crisis services, because it's not just SAMHSA or HHS. There's lots of activity happening across the federal government, whether that's through the Department of Transportation, through Housing and Urban Development, Department of Justice. There's all pieces of work that a lot of agencies are engaged in, and we need to make sure that we're kind of pulling that together in an integrated way so that it makes sense, and we're working not in kind of silos, which sometimes tends to be sort of the risk, but we're working in an integrated fashion. We are also starting to build out an evaluation model, because we want to make sure that we are paying attention to how the system is performing, that we're looking at metrics, that we're disaggregating data, that we have an understanding of inequities in the system, and evaluating those, and then developing kind of a performance improvement process to improve upon those. And in order to be able to do that, we need to have a fully developed kind of evaluation model and metrics that we can look at that help us understand how the system is performing. And then we know that there's going to be a need for ongoing coordination with partners, technical assistance, learning, elevating best practices where we see them in communities, to make sure that there's shared learning moving forward. This is kind of that broader behavioral health continuum. We've been very focused in the 988 office on the crisis services, but it has to be connected to these other elements of the crisis of the broader continuum. Otherwise, it really is not going to be maximally effective. And here are just some samples of services that we know across the behavioral health continuum more broadly that we need to be thinking about, both upstream, downstream, really across the board, to help us make the most of this opportunity for transformation. And then we, moving forward, have been kind of organizing our work in sort of recognizing five drivers or domains that we think are going to be critically important to focus on to build out the system that we think is important and that our partners and the public I think is important and frankly deserve to have access to. And so we're focused on leadership, coordination, communication falls into this category as well. Very much focused on identifying and developing planning to address inequities that we see in the system currently. Leveraging data and evaluation and technology. I haven't talked a lot about technology, but we do need to think about how technology can be of assistance to us in some of these, in integrating care and being able to develop a broader evaluation plan. I did mention workforce, again, trying to pull any lever we can, certainly at the federal level, to think about how we're supporting workforce, and then also working with our colleagues in Medicaid and Medicare, engaging commercial payers to think about ways that we can support sustainable financing of crisis services, because that is a critically important piece. The federal government has a role. We're providing grants, we're supporting activities, but there really needs to be kind of a braided approach here to think about how we're going to sustain these services moving forward. And I think that's it. That was my last slide. Hannah, I hope I fell within the correct time frame.
That was great, and just want to express my gratitude to you, Dr. Palmieri, and to your team at SAMHSA for being such terrific partners. Our priority here at NAMI is that nothing about us without us, and you've really been inclusive in making sure that the peer and family voice is part of this process, and very grateful to you for that. Danielle, I hope we can pull up my slides. Thank you. I'm just going to briefly go over what NAMI is working on at the federal level, as well as our work around 988, talk about some of our priorities and what's coming up in DC. So we have a number of priority areas, and sorry, my graphic didn't translate here, but this is just to give you an idea of the scope. Crisis response has been a huge priority over the last 18 to 24 months because of this unique opportunity that we have. But we continue to advocate for access to care, for diversion from justice system involvement, for the inclusion of peer and family supports, housing, veterans, a lot of different opportunities. And fortunately, there's been a lot of focus on all of this. So we've had some great discussions and advancements at the federal level, and more to come, which I'll talk about in a minute. But we continue to work on a wide range of issues. Dr. Palmieri talked about this continuum of care, and just to break it down a little bit for you with 988. We really see this as the entry point, and this is why we have been focusing on 988 and crisis response so much. These call centers, or call, text, chat centers, are, they provide someone to talk to, and that is one piece of this three-pronged approach. But law enforcement continues to play a huge role in how we respond to crises across the country. And so implementing mobile crisis teams that are staffed by nurses, social workers, peer support specialists, EMS, to respond rather than sending law enforcement is absolutely critical to the success of this. The one unique thing about 988, as opposed to 911, 988 is the intervention. You are talking to trained crisis counselors who can provide support. And that in and of itself reduces the need for an in-person response. But when that's needed, having these mobile crisis teams available in every community is critical to improving outcomes. So that is a huge focus for us, both at the national level as well as with our NAMI state organizations like NAMI Maryland, to make sure that that's something that everyone has access to. And then when you need someplace to go, for some folks are going to need more services than can be provided by a mobile crisis team. Having crisis stabilization options is absolutely critical. Emergency departments often don't have psychiatric professionals 24 hours a day. They also don't often provide the best environment for somebody in crisis. So short-term options that provide a warm and welcoming environment and can help identify what is needed are vital. Call centers are building up that capacity. Dr. Palmieri showed you the amazing stats of how far we've come. Mobile crisis teams are becoming more commonplace across the country, but we still have a lot of work to go on crisis stabilization options. And that's going to be critical to keeping people in the community, reducing that cycling in and out of jails and emergency departments and hospitals that we see far too often. Across the board, we need more resources across all levels of government to make this possible. And ultimately, we want to get to a place just like our children and grandchildren know that if somebody has broken their leg, they can call 911 to get EMS. We want every child in the not too distant future to know about 988, for it to be commonplace, and to know what to expect, to have a consistent expectation across the country that you'll have this range of services. And that's really what NAMI's priority is to make sure that we take advantage of this opportunity to implement this continuum of care. There's a lot of things to improve the crisis continuum of care that we're working on. And Dr. Palmieri spoke to a lot of that. So I'm not going to focus on all of this, but just shows that we're closer to the starting line than the finish line of this work. This is going to be many years to implement all of the crisis services that we need. And NAMI is committed to being at the table. Thank you to all of you who continue to advocate and raise your voice and be involved in this. That's going to continue to be important. We have seen a lot of media coverage about 988 this summer as the transition in July happened. But we all need to be aware that the work isn't done, that this is a continual process to really make sure that people are getting access to the services that they need. NAMI, again, from our perspective as a peer and family organization, we want to make sure that all the individuals that are impacted by our current crisis response are at the table talking about the solutions that are going to work. So we have implemented the Reimagine Crisis campaign and bringing together a diverse group of partners, those who are traditional partners in the mental health space, as well as some that haven't worked as much in this space, from the Major County Sheriffs of America to the League of United Latin American Citizens and ACLU, and the American College of Emergency Physicians, and many more that you can see on this screen. I think we're up to 48 partners on this initiative, and we'll continue to recruit other groups that are impacted and have a stake in getting this right. We need all of their voices to make this possible, and that's part of this initiative. You all can get involved right now for what we're doing at the national level and be part of this campaign. You can text NAMI MD to 82608 right now to get involved. I encourage you to do that. Again, that's NAMI MD to 82608. I'll have this again at the end. But every one of your voices is critical to making this a success. And so I encourage you to get engaged. Beyond 988, there's so much happening at the federal level that I just want to give you a taste of that before we get to questions. This year, the President's State of the Union spent a good chunk of time talking about his unity agenda based on 4 pillars, one of which is mental health care and one of which is the opioid crisis. This was the first time that the President's State of the Union had a focus on mental health in decades. And we are so pleased by the administration's focus here. They've held a youth mental health summit at the White House with voices of lived experience. The Secretary of Department of Health and Human Services has been on a tour, a national tour on mental health, and many NAMI organizations have been part of that, including advocates in Maryland. To really raise this issue and to normalize it and combat the stigma and talk about solutions. And the Surgeon General, one of the first things when he came on board was to issue an advisory on youth mental health. And in it, he said, our obligation to act is not just medical, it's moral. And I think that really speaks to the commitment that we are seeing across the federal level to focus on this issue. There have been 9 congressional hearings this year focused just on mental health, which I think is more than many, many Congresses combined in the past. And NAMI Anchorage, Alaska youth advocate had the chance to testify earlier this year, and her words just stay with me. She said, "We cannot be satisfied with allowing our children and youth to be educated by mental health through social media and searching online. We cannot be complicit in allowing my friends and classmates and your kids and neighbors to suffer in silence. We cannot knowingly let our students experience the confusion, doubt, and harm that I felt." And I think we all know this too well, and this is the power of NAMI, and this is the power of your advocacy to share those stories, and to make sure that the systems that we're developing and working with our federal partners and state partners on are working for us. And so I just want to emphasize that our success is because of all of you and your advocacy, and it is so needed with 988 and crisis services, and for all mental health care to improve that and get what we so long have not had in our communities. This year, there has been a lot of funding put into to mental health care. One way that happened was through the Bipartisan Safer Communities Act, more commonly referred to as the gun violence bill. There was money in there for 988. There was $1 billion for school-based mental health care. And while we were thrilled with these investments, NAMI also felt it was vitally important to reinforce the message that people with mental illness are not violent. Addressing mental health is not going to solve our gun violence crisis. NAMI led a group of 60 organizations in a statement. We were very pleased that the bipartisan sponsors of this bill did not talk about the bill in a way that addressing mental health care would solve this crisis. And these investments are going to be important, but we will continue to make sure that we have honest conversations about this issue, and don't stigmatize people with mental illness as the root of our problems, because we know what discrimination that causes. And just looking to the rest of the year, we have a lot going on. The federal fiscal year started October 1st. We do not have appropriations finalized for that fiscal year, so we're operating on what's called a continuing resolution. Many great investments in the proposed bills for the fiscal year 2023, including for 988. But also a number of congressional committees have been working on mental health packages. That includes reauthorization for many critical SAMHSA programs, as well as a lot of other programs that would radically improve mental health care across the country. So again, if you text NAMI MD to 82608, we'll let you know about opportunities to engage in that. But the end of this year could be very exciting potentially, and there's a lot of opportunity. And this has really been a bipartisan effort in Congress that we're really excited about, because that gives us the opportunity to continue this momentum. Mental health is not a partisan issue. It does not discriminate based on your background. We are all impacted, and having that bipartisan support is critical. One last thing, I'd be remiss if I didn't share information on this, since we are in October. NAMI has a nonpartisan Vote for Mental Health campaign. Who you vote for is your choice. That we're not going to tell you who to vote for, but we want you to know how to exercise your rights, and how to vote. So if you go to voteformentalhealth.org, you can take our pledge to vote for mental health. You'll get reminders about voting over the next few weeks, and how to access different information, and how to talk to candidates about this issue to make sure that it continues to be a priority on their radar. So these are the resources that I mentioned. You can reach out to me at any time, but I'm so grateful for all of you. I have, I think, one of the most fulfilling jobs at NAMI, in that I get to work with advocates across the country who just bring so much passion. And I think the progress on 988 speaks to that, and the role that all of you have played. I will turn it back over to Denise and Kate for any questions we have, but thank you so much for having us today.
Thank you, Hannah and Dr. Ms. Wesleski and Dr. Palmieri. Sorry. Thank you very, very much. A lot covered. I just there's a number of questions I just wanted to thank you both so much for such a great presentation. Also to note that both of you mentioned the importance of the entire system, the entire crisis system. And I wanted to note that our afternoon plenary includes the Maryland, the leaders of the Maryland Behavioral Health Administration to talk about the Maryland State Crisis Planning and 988. So stay tuned. Also, we're going to open up very briefly the workshop for questions. If you haven't already, please post questions in the Q&A to the right side of your screen. If we don't have time to answer questions, all our questions today, feel free to put them in the chat, but also you can send your questions and the name of the session you attended to connection at NAMIMD.org, or submit your question at your end of the event evaluation later this afternoon. One of the questions was asked, and yes, slides and recordings will be available to all participants. Also, I wanted to note that on a Saturday, one of our plenaries will be specifically talking about the election, talking to your candidates in Maryland about mental health and educating them. Finally, I'm going to turn it over to Denise and see if she can fit in a few questions.
So we have a question from Connie Hutchins. Are 988 calls recorded, and what is the privacy situation, John?
Yeah, it's a great question. Calls sometimes are recorded within the system for quality assurance purposes. So there is a mechanism in place where supervisors and managers to make sure that crisis counselors are following protocols, risk assessment protocols, and so forth. So the calls are recorded for that purpose. But people, when they're calling in or chatting or texting, do not have to provide any identifying information, name, location, any information about themselves to be able to access the services. So that is not a component of those contacts when people contact 988.
And the second question is, what response can we expect from a call with a positive suicide response versus a call for crisis support?
Well, I'll try to answer the question. I mean, I think that the general approach to the calls on the Suicide and Crisis Lifeline is to work with individuals in the most person-centered, trauma-informed way and provide the least restrictive response possible. So if people are calling with suicidal concerns, then the role of the crisis counselor in that situation would be to listen actively, to try to engage in safety planning with that individual to sort of figure out what are going to be some next steps. Do they already have a safety plan? Do they have supports that they can access? So the work would be around trying to develop that safety plan in real time to de-escalate the crisis, to provide stabilization and perhaps linkage, onto like the next step in terms of additional supports that the person could benefit from. So that would be the approach pretty much in any situation, whether there's suicidal ideation or not. I'm not sure if that answers the question, but that I think that would be how the crisis counselor would approach that.